Stream is started. Thank you.
All right. Thank you, Mary. This is Sarah Stanton. We have not elected a chair to this work group, so we can do that to move forward, or if you want, I can just walk you through the agenda. It's up to you.
I'll nominate Monty Mason to chair.
All right. So, Senator Mason has been nominated and seconded. Are there any other nominations? All right, I will close the nominations. We will now vote on the nominee. All those in favor of Senator Mason as the chair, please say aye.
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 Those opposed, nay. The ayes have it. Senator Mason is the chair, and I will now turn the meeting over to him.
Thank you, sir. Hey, and thanks everyone for being here. We just heard at our last larger commission, full commission meeting, the urgency associated with the situation that the sheriff's brought to our attention, bringing patients to hospitals and having them stay there for an extended period of time. So thank you to everyone on the team for pulling this together so quickly so we can discuss it and talk about it. I know we have several presenters today, but I thought if it would be all right, we'd start with Commissioner Land to kind of give us a lay of the land, if you will. Sorry. Couldn't resist that. I apologize. We know we're at way above capacity in most, if not all, of our hospitals. And we know we have a bed situation that's leading to this issue. So maybe if you would take us through just a snapshot of where we are at this moment in time, we'll use that as a backdrop to our discussions. And you're going to have to come off mute, Commissioner Land. And is someone going to share? There we go. Thank you.
Okay. So thanks, everybody. Can you hear me now?
Yeah.
Okay. So glad to be here today, and along with my other colleagues from DBHDS. And we have had active discussions during my time at DBHDS with local law enforcement regarding the delays that we're here to talk about today for individuals who are under TDO orders. And we welcome the discussion around the issue, especially as we've been seeing truly an increasing number of delays as Virginia continues to reopen during the pandemic. And so I'm going to briefly touch on the problem, our current efforts to address the problem, and some other potential options for consideration. And these are, of course, from DBHDS's perspective. And we appreciate that law enforcement community and other stakeholders may have a different perception of the issues and the problems that we're facing. But regardless, DBHDS is committed to working together to find solutions for these individuals that we serve and for our state employees as well. Heidi, next slide, please. And this is a slide that we shared at the last commission meeting. So basically, our hospital census is dangerously high. Today, we're at 100%, and we're at 109% for our geriatric patients. And, as you've seen on the left side, among the 8 mental health hospitals, those 6 have had periods of admission closures based on VDH recommendations. And currently, 2, Piedmont Geriatric and Southwest Virginia Mental Health Institute, are closed to outbreaks of COVID-19. On the right-hand side, you'll see Eastern and Western states, and they have not had to close because they have the size and the space flexibility that some of our other facilities don't, to be able to stay open during most of the outbreaks. So while they've had to have some bed closures on units, they have not had to close the full facility to any admissions. But you can see that even with some of those bed closures, they are staying at dangerously high census levels for sustained periods of time. These problems have also been exacerbated by low staffing levels in our facilities, where some staffing levels are as low as 65% of total staff. And then despite all of our efforts at recruitment and retention, the low salaries, this truly high-risk environment make it really difficult to recruit staff, particularly the direct support professionals that are working face-to-face with these employees day in, day out. And I want to be clear again, which sometimes is uncomfortable. When a hospital's full, it means there are no beds left at all. Staff can find space maybe on a cot in a day room or a mattress on the floor in a hallway, but the patient then has no privacy. They are vulnerable to victimization if they try to sleep. There's a lack of staff to provide recovery-oriented treatment in these scenarios. And so these are really improper placements, and they push the census levels above the 100% mark. And when our hospitals are at 100% capacity, that's when those transportation delays of the two PDO patients from the emergency departments to a state hospital occur. And sometimes that can last for several hours or even days. And we understand the frustration with it, but it really isn't unsafe to transport those patients to our facilities when we're not able to offer any, true treatment intervention in a therapeutic environment. So that's one element of the problems with the transportation delays that must be addressed. And I'm going to walk through some potential options in my next couple of slides. So Heidi, next slide. So we have some short-term and long-term efforts that we are working currently to address the delays. So in March, as you know, alternative transportation became available for adults and children statewide, 24 hours a day, 365 days a year. And just as a reminder, alternative transportation services are only for people who are experiencing a behavioral health crisis and who are under a TDO, but they also have to be clinically assessed to be appropriate for such transportation. And then as of early March, I think I gave these numbers to you at our last meeting, G4S, who's our contractor, had made just under 2,300 safe transports statewide, with an average trip being about 190 miles. That means that this service has saved law enforcement over 5,000 hours of time just on the transports. However, as it now has authority to operate, G4S can only ease law enforcement's burden for the transport itself. And it cannot sit with the patients in the ED during the PDO period, even though such a custody transfer would be better for both the patient and the officer. So we're looking at opportunities to expand this service to make more of an impact during the TDO period, which could take a significant burden off of law enforcement. We also have a small team of DBHDS central office staff that are available 24 hours a day to problem solve and seek resolution for situations where patients are delayed. And this team is actually activated daily, if not more than once daily. So they're very active in continuing to look for and support both the CSBs, the state hospital, the ED staff in trying to get an alternative admission or some other even level of care if that's possible. Let's see. Then we also have offering that coordination to all staff and patients. We're changing active recruitment and retention efforts to try to get the staffing back up. And we're also improving discharge processes and the pace of discharge. So we're going to work on that. So that should help to free up beds as well. Long term, we're working with you, other members of the General Assembly, and stakeholders to implement a comprehensive crisis system that can, when it's fully implemented, divert individuals from inpatient care altogether. And then STEP Virginia and behavioral health enhancement are also key drivers long-term in shifting to a community-based continuous care that delays or avoids inpatient care and crises altogether. So those are more those long-term systemic changes. Next slide, Heidi. There are many potential solutions that can address, at least in part, the delays we are experiencing. All of these potential situations that I'm going to mention have not been fully vetted and approved by the administration, but all deserve further discussion and exploration. So these are just ideas that we're bringing forward. We hope that people find value in them so we can continue the discussion and exploring what costs might be, what any negative impacts that might occur or unintended consequences. So some of the near-term items could be addressed more easily either through budget or regulatory actions. And these include, again, that idea of expanding the G4S contract or some program to incentivize EDs to add additional trained security staff, kind of as a conservator of the peace model, to stay with patients while they await transfer, so being able to accept that transfer of custody. This would provide needed relief to law enforcement and help them return into their communities. We're also exploring options that require or strongly encourage hospitals to provide stabilizing treatment in the ED to address their patients experiencing a behavioral health crisis while they await transfer to an inpatient bed. And then finally, We're continuing to work with many private hospitals and other providers to develop contracts and pilots to invest in the crisis system and to build out diversion and step-down options. And then again, to continue to invest in Step Virginia and behavioral health enhancement. We also must look at the challenges we have recruiting and retaining direct care staff at our hospitals. And I discussed this earlier, but also in depth at the last meeting. But as long as the hospitals are operating at high capacity, we have to increase staffing to increase safety. We anticipate having more conversations about this over the next several months as we finish our analysis into the wages and benefits for our direct care staff. We're also looking forward to ongoing conversations about how we can build out the current crisis receiving models that we have in Virginia. These are known as CTACs, and we must also support regional crisis receiving models that provide crisis intervention services, 23-hour observations, and crisis stabilization units, along with no refusal drop-off for law enforcement officers. And then last, I think I'll say we'll continue to try and align our hospital system with a right-size model that includes a small overall footprint of facilities, but with 250 or more beds at each facility. To that end, I believe that we have to look at Central State Hospital, which is currently being constructed with 48 fewer beds than the current facility. And as a current and future regional state hospital, we'll continue to seek these 48 additional beds to meet future needs and to reach economies of scale in a right-size system. And those are my last slides. I do have a couple of reference slides if anybody needs some access to them. Thank you, Senator Mason.
Commissioner, I have a question back on your first slide.
Okay.
So I've only been in the General Assembly, there you go, only been in the General Assembly 8 years, but we've been talking about this challenge ever since I've been here. And if you look the difference between 17 and 18, you see the 7% jump in the state and the coinciding decrease in private. Of course, you weren't here at that point, but can you speak to what happened there and just remind us?
So I believe that what we've seen is that there's been an increase overall in cases in psychiatric crises and TDOs. In that particular time frame, it's since seen a bit of a decline in 19 and 20. But that's only the TDO volume that we're seeing there. There's also a lot of voluntary patients that we've seen a huge increase too. So while I think that it looks like the share of the TDOs is continuing to go up because there's still this large number of them, there's also been a huge increase in the number of voluntary patients in the Commonwealth. And, I experienced that before I was here, when I was in the private sector in Virginia, that we saw a huge increase. We were seeing huge increases in the voluntary numbers as well, just to be transparent. And so, I think too that, we've had some issues with just an increase in the acuity of patients and aggression, and many facilities are only, have a lot of semi-private beds, and so even in our facilities, if we don't have the opportunity to say a no roommate order, but in the private facilities they are able to do that. So if they take a TDO patient that's highly aggressive or acute, they're going to have an issue with having to have a no roommate order, which then decreases the capacity that hospital has. And that's just from my personal experience. But I do think that there are ways to incentivize the private facilities either to open more private beds or to harden their units or get better staffing. And we're willing to help support those types of initiatives in our contracts so that they can take some of this more aggressive, assaultive patients, or they could take step downs from us once we've stabilized them somewhat, getting some of those more medically complex, getting the competency in their psychiatric units to maintain some of the more medically complex patients. That typically those are the types that come to us, and geriatric patients, so that have a lot of medical comorbidities. So I think there's some ways that they can do better, and there's some ways that we can help maybe incentivize them to do that.
Okay, Thank you. We'll definitely discuss that more in our discussion period. And last question I have on your slides is, I think the third one, you said require EDs to provide treatment when transport is delayed. So they are not provided. Could you explain that a little further for me, please?
So I don't think 100% aren't doing that, but many hospitals don't have psychiatric services for their ED patients, or even if they don't have a psychiatric unit, even maybe for their med-surg bed patients. And, when you have a heart attack and you go to an ED, they have services for you. If you have a stroke, they're going to be able to do it. But for some reason, we haven't made it that, and about 20 to 30%, I believe, of all the ED patients are in psychiatric crisis or having some sort of behavioral health issue that's coming in. And yet we haven't gotten to the point where we're supplying that in each of our EDs. And so I'm wondering if we can't have some sort of conversation around that. Because, it is an emergency medical condition. It does need to have an intervention. And so what can we do as a state to get better about that?
Okay. Thank you, ma'am. Other questions for Commissioner Land?
Mr. Chairman.
Yes, sir. Delegate.
Thank you, Commissioner Land. I appreciate what you had said. At the last meeting, that's the commission meeting that we had heard situations where sheriffs were staying with an individual for days at a time, not just a few hours, but days. Mm-hmm. And that is the problem what we're trying to solve. And I don't know if that's I don't know how frequently that happens. I was going to say it's anecdotal, but I think it's more than just anecdotal. Do you have a sense if there's a particular sort of, you did a heat map on the Commonwealth, if there was a hot region where this problem is happening much more frequently than others? What I'm getting at here is the solutions that you offer here. Can they be done in every region? In other words, can every hospital, in other words, do that second one for the EDs to provide treatment? Do they have the capacity to do that? And I'm wondering if you also can you comment on discussions with private hospitals about any of these suggestions?
Yeah. So, where we see the most, I'll call them complaints or issues brought forward to us is from the Southwest Virginia area, I would say, around the delays. And I do have Angela and Suzanne Mayo on the call, and if you could corroborate that would be great. But that's what I hear most about.
Okay.
That is correct, Commissioner. This is Angela Harville.
Okay.
And then we've been talking internally. I don't know that I've talked a lot with Jennifer Wicker at VHHA about a lot of ideas over the years that I've known her. And so I'm sure that would not be something that would be, these ideas would already be aware to that stakeholder. We have not talked about that with the law enforcement. So these are new potential solutions to bring forward to have more discussion about and flesh out and vet and see, what is possible, what isn't possible, what level of support would the state need to do some of these things. So these were just some newer ideas. The second bullet,
Follow up, Mr. Chair.
I'm looking at anything that I think could help.
Yeah. Follow up, Mr. Chair.
Delegate.
Commissioner, and I know that I'm very sensitive to the time that law enforcement is spending, but I'm also much more sensitive and sympathetic to the patient that is having to sit in this situation, and recognizing that what the problem that we're trying to solve in this work group is just temporary. The bigger problem that we need to address is the bed shortage situation. That is the problem right there. And so whatever we throw money at this problem, then it's just a temporary solution to this. We've got to solve that bigger problem. And so, I'd be interested to hear what the hospital's response is to any of these things, particularly given that Southwest Virginia seems to be a hot spot. I'm sure there are others, but that seems to be the biggest issue there of whether or not it's possible that just a simple throwing money at this problem to incentivize hospitals to, hire different securities or sitter options, as you suggest there, or their capability, if given the option, to treat people in the emergency department. Because as you mentioned, Commissioner Land, the privacy, that's very important for the individual, and making sure they're not taken advantage of during this very vulnerable time. So I'd like to better understand whether that the region has the ability to deal with it. And maybe the answer is not just one of these, maybe it's multiple.
Delegate Hope.
Thank you, Mr. Chair. Yes.
This is Jennifer Wicker with the Virginia Hospital and Healthcare Association.
Hi.
Just to let you know that I will be addressing some of those items that Commissioner Land mentioned in her presentation. So it appears that we are on the same page, even though we have not had an opportunity to talk prior to this meeting.
Thank you. Thank you, Mr. Chair.
Excellent. Delegate Ranson, anything for Commissioner Land?
Mr. Chairman, I just want the commission to know and that it's not just in Southwest Virginia. I think that this is a statewide issue, the bed shortage, but also law enforcement sitting in the emergency room with patients long term. And so I just maybe Southwest is heightened because they're talking about it, but the sheriff that spoke last week, he's from Gloucester. So,
Right.
This is a statewide issue that's been going on for a long time. So I don't just want to concentrate on Southwest Virginia. It's a statewide issue that's been going on for a long time. So I want to make sure that we point that out.
I agree.
Thank you, ma'am. And we've been joined by the legendary Delegate Vivian Watts. How are you, ma'am?
I'm just fine, my former seatmate. No, I do not have any questions at this time. Thank you.
Thank you, ma'am. Well, thank you, Commissioner Land. In our discussion, I think we will definitely want to dig into more of the pilot work that is in front of us that we've passed that we haven't quite gotten to yet, but hear some ideas of what we have on the table and what you're anticipating. But for now, we'll go to Jennifer Wicker from the Hospital Association. Ms. Wicker, thanks for joining us.
Good afternoon, Mr. Chairman and members of the work group. I'm going to attempt to share my screen, maybe not. Can you all see that?
Not yet. No, ma'am.
Okay. Give me a second, please.
And Jennifer, this is Sarah. If that's not working for you, I have distributed the PowerPoint to our members ahead of time. So at least the members of this work group would have them in front of them for me to use the paper version.
Okay.
Does someone need to share authorization with her, or should she have it?
No, I should have it. I just now can't get back to it. Hold on.
Oh.
We might be getting there.
There we go. We're heading that direction. We can see
We're
your
going in the right
desktop.
direction?
Yes, ma'am. There we go.
Okay.
Perfect. Give the floor.
Okay, the stressful part is over. Thank you all so much for the opportunity to present. As I've said, my name is Jennifer Wicker. I'm with the Virginia Hospital and Healthcare Association. And this afternoon, what I would like to do is provide an overview of some of the trends that our hospitals are seeing in the emergency department, as well as what is impacting bed availability throughout the community hospital system. So our hospitals, as everyone already knows, within our hospitals, we're seeing very long lengths of stay, especially as it relates for children and adolescents. And as someone indicated earlier, the lengths of stay are not over hours, they are over days. In addition, the inpatient lengths of stay have increased across all populations, within our hospitals, which have a significant impact on bed availability. Our hospitals struggle to recruit and retain sufficient behavioral health staff, which would allow them to operate at their full licensed capacity. And finally, special populations are consistently hard to place within the inpatient setting. And we're seeing that around young children, especially, and individuals with severe developmental disabilities. I'd like to take a moment to talk about the children and adolescents. And what we're seeing is that the pandemic has caused a disruption in normal behavioral health supports, especially as it relates to the school system, and that's resulting in delayed community interventions. So we are seeing a significant amount of patients who are coming into the ED for treatment. And when they're presenting, they are presenting with a much higher acuity than we were seeing in the pre-pandemic era. There are only a few pediatric behavioral health units in Virginia, and they are all, they're often full due to COVID-19 and other medical conditions that our hospitals are dealing with. And as we've talked about for many years, child psychiatrists are especially difficult to recruit. So quickly, I would like to talk about why patients are boarding in the emergency department. And again, this is from the perspective of the hospitals. And at the peak of the pandemic, there was a significant reduction in the available behavioral health beds because our hospitals wanted to ensure proper COVID-19 infection management. And so they took semi-private beds down to private beds, and that did impact bed availability. A majority of our hospitals are now have done away with those protocols as they have learned to better deal with the COVID-19 management. But there are still a few facilities that have limited beds because they have because of their infection controls. Staff shortages across all behavioral health personnel have put significant limits on the number of available beds. As I mentioned earlier, without appropriate staff, our members are unable to open up all of their licensed beds. And in the past, we've seen shortages around psychiatrists. We are now seeing it around nurses, around techs, around social workers. So it is truly across all behavioral health staffing. And I also mentioned earlier that the patient's acuity is significantly higher than what we've seen in the past. And as a result, it's requiring more time for inpatient treatment. And that longer time is increasing the length of stay of patients while they are inpatient, in an inpatient admission. And as you can imagine, that is taking up beds and decreasing the amount of time that we're able to turn over beds in a quick manner. There are patients who are refusing to be tested for COVID-19 in the emergency department, and that is causing delays because a COVID test, whether negative or positive, is required before a patient will be admitted into any facility. And then with our children and adolescents, for good reasons, many families are preferring for their children to be admitted near home. And so that is also causing delays as beds are searched for. So how our hospitals are adapting? When possible, our community hospitals are admitting patients to medical floors. But unfortunately, the medical floor setting is not the best setting for an individual, especially because they are not ligature free, which is a requirement for behavioral health patients in order to keep them safe. And so hospitals are having to add staff to be able to have a one-on-one sitter remain with the patient while they're on the medical floor to ensure that they do not hurt themselves or others. Our hospitals are utilizing some of their staff to conduct bed searches in an attempt to find an appropriate bed placement. And our members have shared with me that they are working on protocols to implement treatment in the emergency department. Now, that has not been a practice that has always been done in the emergency department, but as we're seeing patients remain in the ED for many hours and many days, it has become necessary, and our hospitals are putting in protocols to begin that level of treatment, which includes psychiatrists rounding in the emergency department, providing medicine, and when necessary, they are utilizing telehealth, although that is a very expensive endeavor, but some hospitals are utilizing that method. They are increasing coordination between psychiatrists and emergency physicians, as well as increasing coordination with our CSB partners for step downs, and that will help to make more beds available to admit patients from the ED. And then I wanted to take a few moments to provide you some updates on how our hospitals are currently partnering. This includes the addition of child and adolescent beds. As you all may know, Children's Hospital of the King's Daughters will be opening up a child and adolescent facility in 2022 that will add 60 beds. That will be done in 2 phases. But in the meantime, they are working on adding 6 additional beds within their ED to hold mental health patients. And they are opening a medical psychiatric unit with 7 beds this fall. Carilion Clinic, which has been mentioned by Commissioner Land on many occasions as it relates to the private hospital pilots, they have initiated a comprehensive psychiatric emergency program, and that CPEP program has been established to divert inpatient admissions. With CPEP, they're able to provide intensive treatment in the ED as well as intensive case management. And they are seeing a lot of success around diversions for inpatient admissions. And with the additional funding that we'll be getting from DBHDS and that you all appropriated, they will be able to expand that program. HCA Tucker Pavilion at Chippenham will be opening a 12-bed geriatric unit in July, and they are also working on reopening 37 beds that had been closed due to construction, and are working hard to expand adolescent outpatient services so that we have options for individuals alternative to inpatient, an inpatient setting. Riverside is developing an inpatient program for detox and addiction. And the work that they're doing at Riverside is currently being considered by DBHDS for the private hospital pilot funding. And Inova has accelerated the hiring of an emergency service psychiatrist in order to increase rounding and treatment in the ED. And our recommendations we just have 2. And one of them has already been mentioned, and that is funding and the authorization to allow alternative transportation providers to sit with patients in the ED. And all that, although this is not going to solve the problem, but as we are working on these other solutions, this will help to alleviate the pressures on law enforcement. And our members have told me multiple times that they have beds that they cannot open because of staffing. And as they look to hire travel nurses, that cost is very expensive. One member shared with me that pre-pandemic, they were paying $34 an hour for an RN. And as they look to hire now and are looking towards travel nurses, they are looking at paying $110 per hour. And in order for them to open up their unit completely, they would need to hire 6 nurses. So that's a very expensive cost. So any assistance that can be provided with that will help to accelerate the ability to be able to get the staff and open up the beds. And then we continue to support and have always been supportive of all the efforts that are in place to expand community-based services so that we have options other than inpatient care for our most vulnerable in the Commonwealth. And I'm happy to answer any questions.
So it's interesting to me that you say your hospitals, thank you very much, by the way, man. Your hospitals are beginning treatment in the ED, beginning to discuss treating an ED, whereas that has not been a practice in the past. You know, as a layman, that surprises me a little bit in that, you know, you may not always get your ultimate treatment in an emergency room, but in all cases, I would assume that you're getting stabilization and help there. Why is it different? Is it just the lack of psychiatric training there? Or why is an emergency room doctor not doing the first phases as a matter of course for these patients?
Well, you actually make a good point. There is stabilizing treatment that exists within the emergency department. But when you have individuals who are staying there for days on end, that is something that is not the practice of the emergency physician or even the hospital ED staff to provide significant treatment within the ED. And obviously the treatment that they are starting as a result of the extensive length of stays in the emergency department does not compare to the treatment that they receive on the unit. It is only to provide, support until an admission can happen. But in terms of being able to provide the groups, the counseling, all of those types of things that a person would get if they were actually admitted, that is not happening on, the ED, because that's not the space in which it should happen. And it would require pulling staff from the units in order to be able to do that. So the stabilizing piece was happening prior, but because individuals are staying a lot longer, our hospitals are adapting and providing more levels of treatment within the emergency department.
I have so many questions about the stay of days. How do they get fed? How do you rotate deputies? What's the legality of actually us being able to do it? But before we dig into all that, do you have just numbers for us? If we picked a random 24-hour period, how many people, do you have numbers for us? And then back to Delegate Hope's question, by region particularly, that we have had people in an emergency department, say we drew the line at 24 hours, greater than a 24-hour period. Can we get those numbers by area, by region, by facility, and kind of dig into those deeper?
I do not have those numbers for you now. I do have some numbers from some hospitals who, as I was gathering more information on what they are seeing, provided to me. And on the high end, there was one hospital in the Tidewater area that had an individual that stayed in the emergency department for 10 days. Now, I don't know whether or not law enforcement was there for the full 10 days. But there are situations, and I would say that those happen less. But it's definitely over a couple, 2 to 3 days that we're seeing lengths of stay. And as I mentioned earlier, with the children, I am hearing a lot more that the lengths of stay are longer than 2 to 3 days. And that just comes down to, we do not have a significant amount of inpatient beds for our smaller children. And there is a lot of stress that people are dealing with coming out of isolation that is increasing the overall need for the inpatient care. And like I said earlier, not having the robust, for lack of a better word, outpatient and school supports that we had prior to the pandemic has just made people sicker.
Right. And I appreciate a significant portion of your presentation was during COVID, but I know that I would be interested in taking a year pre-COVID and coming up with numbers of people that were there greater than 24 hours or a period that we can all agree on. And then during COVID, how many cases are we talking about by region, by area? And then I'd just love to dig into some to just understand, how did we ever get to that situation? Delegate Ransom?
Mr. Chairman, I have a question maybe for Commissioner Land or Ms. Wicker, just to help me understand as a parent and certainly as an advocate for mental health. When a person comes into the emergency room with an ECO or TDO and they are there even after 24 hours in crisis, why wouldn't a doctor or a nurse in the emergency room call the local CSB, and I'm just trying to understand this so that I can navigate through this process myself. Why wouldn't they call someone and say, listen, this person is in crisis, they need help. We don't have a psychiatrist here in the emergency room, but right now they are in need. They need help right away. We need to get them on some type of medicine. What do we do right now? Because right now they're with law enforcement and they're handcuffed to the bed. Why doesn't that happen within 24 hours?
So I'm not sure why it hasn't happened. In the past, I've always advocated for that, not from necessarily calling the community services boards, but our ERs know that they have a large number of behavioral health patients that will, as a percentage of all of their admissions to the ED. And so we need them to proactively design services. Now we're doing VMAT for the pediatricians to be able to help in their offices and getting their competence built up. We can do that for ER physicians as well. We can do a program for them if they don't feel competent. But also, as Jennifer mentioned, if they're beginning to work on those medication protocols, then their physicians will have that support, and it'll be in their EHRs, their electronic health records, that can help them with that. And then it would reduce the level of consult that was needed by external or internal or virtual psychiatry coverage, which would be a much more economical way to do it. And so that's another avenue that we could look at for increasing. And that's another thing is that some patients come in and they're actually voluntary, but they can't find a bed. And then they start ramping up, escalating in the ED because it's not a great place for them to be. And it's very chaotic. And if they stay there for a while, they end up having to be TDO'd, which just increases the issue. And then they also have those behaviors. When they start escalating, they're documented. And when you try to call clinical to get somebody to accept the patient, then they don't do it. So it would just help all around, I think, if we could find a way forward. And I'm glad they're finally looking at it, Jennifer. That's awesome.
Anything to add, Ms. Wicker?
No, I think Allison made the points. I again, you know, I guess I will add one quick thing and just say, ideally, we want to have a system where an individual can seek care in the emergency department and then be transferred to the appropriate setting. I know that right now we're not there. And because we're not there, our hospitals are working on ways to be to adapt to the environment that we're in, and that includes providing care within the ED. I will say that I've had conversations with about 20 different members over the last week, trying to understand what everyone's doing, because everyone does something a little bit differently. But I do agree that there is an opportunity to have a conversation about how we can ensure that people don't decompensate in the ED when we're waiting to find treatment. And I look forward to the conversation, and I know our members would be open to having that conversation as well, and providing a lot more expertise than I would be able to.
Yeah, Commissioner Lansing, Dad.
Yeah, I was just going to say that also, I think that if we could begin that stabilizing treatment, that medication, and sometimes it's just getting them back on their medication, then it could be potentially that during the bed search that they would stabilize enough to go to an outpatient setting. So that's another positive of going ahead and getting that done.
Thank you. Delegate Watts.
Thank you, Mr. Chairman. So patients present themselves in the ED in all, I assume under all circumstances. So I'm being specific about an incident that occurred here approximately 5 to 6 years ago, when the individual presented during at least a 20-day period of repeated mental crisis in her mid-30s, with her first hospitalization being when she was 14. The emergency physician tried twice to get the magistrate to do a commitment order. And the magistrate refused. The physician was concerned, I believe, about blood chemical tests that she was looking at, but lab tests that caused her great concern besides the behavior. How common is it for our courts not to respond in this way? Ultimately, yeah.
I'm not sure I know the answer to that. I don't know if anybody else from DBHDS has a feel for that, but we could look into it. I mean, I'm sure, and Jennifer Faison, I think, was on the call, if she knows if they maintain any kind of records of, they asked for the TDO, but we did not get a TDO approved.
Mr. Jones came off mute. Do you have something to add to that, sir?
Thank you, Mr. Chairman. It's my sense from talking to the sheriffs that that is not common. I have a sense that most of the time, almost all the time, when the magistrates are approached with the evidence for TDO that it's given, let me just qualify that by saying that's my sense. I know that when things go wrong, sheriffs complain, and they call me a lot, and I just haven't gotten that complaint. So that's what that's based on.
Mm-hmm. I thank you for that, and I will pursue it then independently. But since I spoke up, I will just say that this ended with Natasha Matana's death because she had not been appropriately treated, and therefore, and it's also since it's Fairfax, Alexandria, also we're dealing with law enforcement, not just the sheriff's office. So this is where I just want to make sure that the standards as far as admissions by a medical doctor are something that are nothing falls through the cracks statewide, commonwealth wide.
Thank you, ma'am. And Delegate Watts makes a point that of the reason that I asked to have COVID numbers and then pre-COVID, because that's 5 or 6 years ago. So, we're not just talking about something we've been wrestling with in COVID. While it is certainly made it more difficult, this has been going on for some time. So I'd be interested in the numbers pre and post. Delegate Hope.
Thank you, Mr. Chairman. And I'm trying to think through in my mind, because I think the work group is charged with coming up with a recommendation for the full commission of how we're going to deal with this. And Ms. Wicker, you gave some recommendations. I think what we're trying to do here is stop the bleeding. And again, I've said this before, and I'm going to keep saying it. I don't think that this solves the real problem here. The real problem is the bed shortage. And I'm trying to think in my mind, if we're going to throw money at the problem, is it better to throw money on this end of sitting with people, or is it better to use that money and throw it on having more beds in the system? And I know people have different thoughts about all of that. My question to you is, you gave some preferences or some recommendations. Do you have a preference of those three? And I will couch this by saying, again, I agree with Senator Mason. We really need to have data. I mean, if we're talking about certain regions that are having this problem the most, I don't think you're going to hire a team of people in a particular region to sit there and not do anything. And if we're talking about overtime or something like that, that's different. But you're not going to necessarily retrain staff or have people ready to go at different facilities when we don't really have the problem in that facility or in that region. And so we need to know where these problems exist so that we can station people accordingly to deal with that issue. But my question was, Jennifer, I'm beating around the bush. Do you have a preference of those three recommendations that you made?
All three, but yes, I have a preference. I mean,
of the two,
that's a difficult question because it's so complicated and everything is so interrelated. Obviously being able to open up beds, everyone talks about the bed shortage, and I like to call it a workforce shortage so that it's a more accurate discussion because we have beds. We have hospitals that are unable to open all of their beds. because of the workforce shortage. So if we were able to infuse some money temporarily into the system so that our hospitals could have some assistance with paying for these travelers, not saying all, pay the full freight, but to help with that cost, that could get some beds opened quickly, assuming we can get the people hired and all of that stuff. But while we're waiting for that process to happen, we still have the situation where we have individuals who are staying in the ED for a long time. Law enforcement needs to get back to the community, and we don't want to have the risk of somebody walking out because the time has expired and we have a bad outcome. So my preference would be staff, but I think the sitters are just as important.
Mr. Chairman, if I could ask Ms. Wicker, I would like to see, I don't know about my colleagues, but I would like to see a request of what that would look like budget-wise to get more. You have the beds, you said, it's just the staff. What would that look like and where would you put them? Where would you prioritize the staff? What region, which facility, whatever. And I would like to see what that would cost.
I'm happy to work on that. And I would say to you that I think a priority should be the children and adolescents. We have Kempsville, who has a lot of beds that aren't opened. They built a lot of beds recently that aren't opened. And so I'm thinking about the child and adolescent side, but I can work on that. And I'm happy to provide a couple of different scenarios for you to be able to make a choice.
Thank you, Ms. Wicker. And just to emphasize to Mr. Chairman and my colleagues about what I'm thinking is that in my mind, if we want to spend more money on paying overtime to sheriffs, or we want to spend more money on training security personnel or someone to sit, or is it better to bite the bullet and spend money on staffing the beds in the private facility? Then we just need to decide whether as a policy matter, is that a better place to park our money to solve this issue? Because again, I really think that what we're doing here is just stopping the bleeding. We're not solving the problem. And the problem is the lack of these beds or staffing to support them.
Yes, sir.
Thank you.
And you also mentioned telehealth being an expensive option, but it seems to link very well with what Commissioner Land's talking about, getting some initial treatment if you do not have a qualified physician there to do such. So, I'd be interested in telehealth's been one of the successes of COVID, so why wouldn't be able to float down to this discussion? It looks like it might be a nice link as well. Delegate Watts, did you have a follow?
No, thank you. I'm sorry, I didn't take my hand down.
No worries. So, Mr. Jones, you got us here, but if you would like to, I'd like to let you close and see if we could go to Jennifer Faison next, because that you heard Ms. Wicker talk about and Commissioner Land also talk about, the call to the CSB. Your sheriffs are sitting there. We're trying to get help. Dr. Ward talked to the full commission about the ACT teams that we call them a PAC team on the peninsula, but those are she deemed to be almost mobile hospitals. We've also spent a great deal of time talking about Marcus alerts and trying to have a team of professionals going out to respond to those. It strikes me, if we're talking about those conversations in the community, if we've got people sitting in hospitals not getting treatment, it looks like we might need to send those teams into the hospital if they're sitting there after a long number of days. But that all sounds great from our seat, doesn't it, Ms. Faison? So why don't you give us some of the realities of what you're looking at going into those efforts and your thoughts on this topic. We appreciate you joining us.
Sure. And as always, happy to participate and provide support to these efforts. I'll be brief in my remarks. My understanding of the purpose of this work group was really to focus in on law enforcement and solving that particular issue. So my comments will be really directed towards what is the role of the CSB in the moment of time that we're talking about. And just to you all are familiar with this, but the CSB pre-screening clinicians are a critical part of this response system. And their role in this moment is to provide an objective clinical evaluation for individuals who are in a behavioral health crisis. And the goal is to connect those individuals to life-saving treatment, because that's what we're talking about here, in the least restrictive environment. So as clinicians, they are always looking for the least restrictive environment in which to get that person connected to treatment. And so I will point out just one thing. I have a couple of responses to some questions that have been raised, and wanted to, at this moment, talk about one of Commissioner Land's slides, and it's one that we've seen, and it's the one that specifically shows the number of TDOs that the state hospitals are managing and accepting versus the private hospitals. And on that slide, across the top of the bar graph, what you see is actually the number of TDOs. And you'll notice, if you go back and look at that the number of actual temporary detentions has remained fairly steady over time. So we're not talking about a huge increase in the number of actual TDOs. It's just a shift in where they are going for reasons which both the commissioner and Jennifer Wicker have outlined for you. But I wanted to make sure that part is clear. What we do know, though, is that there has been a marked increase in the number of evaluations. So the number of folks that the CSB pre-screening clinicians are evaluating is going up, but the number of TDOs is remaining steady. And I think, you could draw a number of conclusions from that, but one of them might be that the evaluation process, at least, is getting to that getting to the population of folks who rise to the level of a TDO appropriately, right? So I just wanted to make sure that I pointed that out as part of this conversation. But back to my prepared remarks. So we're talking about CSB pre-screeners, and it's their clinical and ethical responsibility to try to connect folks to care that are or to treatment in the least restrictive environment, but also an environment that's appropriate to their need. And so that's a mandated critical function. And within the larger process, in the moment in the emergency room where this evaluation is occurring, the pre-screener has that responsibility for the clinical evaluation, presenting evidence to the magistrate and all the things that are connected to that. But they also have a unique and important role that is often misunderstood or maybe not understood wholly. And that role is really in supporting and linking and managing the disparate stakeholders that are in this process, that are involved in this very important emergency behavioral health response. And so we're talking about many of the players that you have in front of you today in the Zoom meeting, but we're talking about police, sheriffs, we're talking about 911 dispatchers, we're talking about hospital emergency providers, security staff, state psychiatric hospitals, private hospitals, magistrates, and then CSB and other mental health providers. So the CSB, in addition, as I said, to that role of the clinical evaluation, we're trying to make sure that we are being good partners with all of the stakeholders in that moment, so that the individual, if it's that they need a TDO, it's that they're getting connected to a hospital bed. If they do not meet TDO criteria, it's getting them connected with a safety plan or with the appropriate services and supports that they need in that moment. And I would also like to emphasize that Senator Mason and Delegate Hope really did hit on this, and it is that our system has been struggling with this and in danger for years. This moment right now, where resources are reduced and crises, especially behavioral health crises, are on the rise. we are having difficulty finding inpatient hospital beds. We recognize and appreciate the dire conditions in the state hospitals when they're running at 100% census, and it creates an environment of tension, which is what you're seeing here is the impetus for this work group, really. And so if the state hospital is full and they have to delay an admission, then there's, it sets up kind of an inherent tension between the role of law enforcement and everybody else who's in that emergency department, and it's just part of the system. So really, the experience of law enforcement in this process is a symptom of the larger disease, which we've been talking about, as Senator Mason pointed out, for a long time, and that is just the access to inpatient resources. And it's also important to point out that the pre-screeners in this process, they don't have any authority to resolve any of these tensions. It's their job to assess the individual and identify the appropriate supports. They cannot make beds available. They can look for them and they can find them, which is part of their responsibility, but they can't make them appear. We can't take custody of individuals. So we can't, in that moment, fix that problem for law enforcement, the custody issue. So there are a lot of things that the CSB pre-screeners can't control. And we also don't control when or why an individual is going to need an assessment, and whether that assessment is going to result in the need for an involuntary hospitalization. That's just how it is. The behaviors present themselves and they get that clinical evaluation, and maybe it's a TDO and maybe it isn't. And so, in this environment, the pre-screeners, they face challenges, but they are fulfilling their roles proudly, serving in their communities 24 hours a day, 365 days a year. And again, really patient-centered and focused on that clinical evaluation and the connection there. So if I may, in addition to pointing out the TDO data and the, just pointing out that the overall number of evaluations have increased, but the number of TDOs has really kind of held steady. We would agree in the CSBs, the VA-CSB as an association, that, you really do need to focus on additional funding for the crisis continuum. And part of that is STEP Virginia related, and part of it isn't. When we talk about, the crisis continuum has always been a part of STEP Virginia, but there are elements that have been added to that, including the Marcus Alert. So really getting in there to address full funding for the crisis continuum will be important. I think Project Bravo will have some impact on that, but we have to recognize that, that's a Medicaid reimbursement stream, so it's helpful, but it's certainly not going to provide coverage for every individual who finds themselves in need of behavioral health services. And I think the question about Delegate Hope that you raised, where is it that we want to place these resources to have the most impact? And that's two wheres, right? Geographically, where should we be focused? And then where in this process would it make sense to plug in some resources? And, at some point it becomes difficult, and we saw this with our training centers as well. You have to be funding at a level that is uncomfortable, because you need to be fully funding the inpatient resources that you need, and you have to be plowing money into the behavioral health community system at the same time, until the point where your investments in those community-based resources are such that you are able to maintain the focus there, and perhaps reduce the need for that inpatient level of care. And when we talk about funding, the we're, of course, very sympathetic to the workforce issues. That's, of course, throughout the behavioral health system, not just in the state and private hospitals, but also any provider will tell you that they're running vacancies in very high percentages. And if you were to drill down into particular programs, you'd see that in many ways it's been decimated. But if we're talking about one thing I will say, and this won't come as a surprise to anybody, but if we're talking about the potential to use public dollars, so state general fund dollars, to support or subsidize hospital beds in private hospitals, I think it would be important to ensure that once those beds are open and online, that they're taking TDOs. That's part of the conversation and part of the equation. So we wouldn't want to create capacity that wouldn't ultimately help to solve our problem. And I'll stop there, and I'm sure there will be some questions that I will try and answer.
Commissioner Land, did you want to add something, ma'am?
No, I agree with what Jennifer's been saying. That same issue happens at the state hospitals, that the support to change how we staff to be able to operate 7 days a week. For instance, we don't do discharges and things we do accept admissions on the weekends, but we don't do discharges. And our discharge planning takes so long that patients are routinely many days over. When they're ready for discharge, they stay. So really looking at how we do our discharge planning, we do have a work group on that, and funding to be able to operate and do discharges on weekends so that we're offsetting and not getting so full will also stop many of the delays in the AEDs happening as well. And so that's both funding that would help with the CFB that works with discharge planning, as well as our state hospitals for the treatment team to be meeting and agreeing that a patient everything's been done, that patient can actually be discharged instead of waiting till Monday or Tuesday. And then they've stayed another 3 or 4 days. So we could really, I think, increase that throughput and have beds available for patients waiting to get in. So another option that kind of piggybacks on what Jennifer Faison was saying.
Sure. And Ms. Faison, you said the TDOs have remained fairly constant. If you look at that graph, with a 7% change between 17 and 18 public versus private hospital. You also said your evaluations have gone up, which seem to be two things. One means we're doing a better job maybe evaluating and doing community work. But does that also add to the stress of the voluntary commitments that Commissioner Land spoke to when I asked her that question earlier?
Maybe. So the goal is you want an individual to choose to go voluntarily.
Sure.
That's what you want.
Right.
And in some instances, obviously, that person is not willing to do that, and they're adjudged a danger to themselves or others, and that's how they get wrapped up in the TDO process. So I don't know that it would be a straight line. I agree with you that, we're getting a whole lot more comfortable as a society talking about behavioral health conditions. The number of evaluations have increased because, probably population increase has something to do with it. There are a number of reasons for that. But I don't know that you could draw a straight line between the evaluations and the outcome of that and voluntary admissions, because we're not going to see if somebody's going voluntary, they don't need to be evaluated for an involuntary admission. Right.
Okay.
Yeah.
Sure. Okay. Delia Watts, were you thinking something, ma'am?
Yes, on funding. The American Rescue Plan money will start flowing, I believe, this month, although we still don't have good guidance, but it'll flow through 2024. Since there's been so much said about the effect on COVID and how it has affected so many people's coping with mental health issues, I would ask either Commissioner Land and or Taylor and or through our full committee's budget committee to really take a solid look, so we're right in line as quickly as possible. If there is anything that we can use the American Rescue Plan money on, I'm thinking particular telemedicine and getting that up and available structurally in as many areas as we possibly can, rather than staffing. I'm backing away from staffing because that's ongoing. But to identify anything that is something that would put us in a better posture on on investment using the American Rescue Plan money.
Okay. Anyone else for questions on Ms. Faison? But boy, consistent theme here is workforce, right? I mean, I'll give you credit, as I always do. You say, what's the best time to plant a tree? 20 years ago. And we've got some serious workforce challenges everywhere, in that my local ACT team, PAC team said that they are ready to start a second, and they're managing about 90 patients on their first, but they don't know that they could find the actual resources and the workforce to staff it if they did have even the money to fund it. So anybody else for Jennifer? All right. Thank you, ma'am. Mr. Jones.
Good afternoon, Mr. Chairman and members, and thank you for having me on the agenda today. I agree with much of what's been said, but I want to emphasize 2 or 3 points. And I've got a handout that's in your package. I don't need to load it. I can go through this probably more efficiently just discussing it with you. The overall and the long-term issue, we believe, is a lack of beds. And it's been a lack of beds. And we have deputy sheriffs sitting in emergency departments and hospitals for days at a time looking for a bed. There's no other way out of it. We've got to have more beds, whether they're public beds or private beds. That's above my pay grade, but we do not have enough beds. And that may be, to some extent, more of a long-term issue, but I'm concerned when I hear that we're getting ready to close another 48 beds at Central State. And I hope you can have a conversation about that. Secondly, I would say this is not a Southwest Virginia issue. If some of you may recall, at the last hearing, there were 2 sheriffs with me on the presentation. One was Sheriff Warren in Gloucester County, and he had actually done a poll in his area, and he listed the numbers down and the sheriffs and the localities, and there were days after days after days repeatedly of deputies being stationed in emergency rooms in hospitals, sitting with patients. And it also comes from South Side Virginia. If I had to summarize, what type of locality we're dealing with this problem, it would probably be rural areas, no matter where they're located, or semi-rural areas. I seem to get more concerns from sheriffs in rural areas. And so we can easily do a survey to find out more on that, Mr. Chairman and members, and I know you had mentioned it. The overall concern is not the sheriffs. It's not and it is a concern to us, but the overall concern, there are 2 of them. One is a public safety concern that we deal with when we have a sheriff's office with 2 deputies on patrol and we have to leave for days at a time. We're having to pull other deputies out of bed, put them on patrol, and that's creating a significant cost to the sheriff's office and the locality because of overtime funding. That is a federal requirement. The overriding concern is no patient is the patient. No patient should have to wait days in an emergency room standing by a deputy sheriff to get mental health services. So to address that is the overall concern. Now my 2 immediate stop the bleeding recommendations are that we have 2. One is to provide the overtime funding for these localities and these sheriffs that are having these deputies set in the emergency room. We did the Sheriff's Association submitted a budget amendment. It was $3.8 million for the biennial. And it certainly relates to COVID, and we hope that maybe it could be considered during the rescue funding process. When you couple that with our turnover rate in the jails is 35%, the turnover rate among our law enforcement officers is 21%, and the turnover rate among our court officers is 27%. We're having a really, really difficult time attracting and retaining qualified law enforcement officers, and then when we're using them for this, it's distracting from our mission of public safety. So the other recommendation is the expansion of the alternative transportation provider, and we also put an amendment in on that. We think it would be certainly more desirable to have the contract expanded to provide a alternative transportation provider sitting with the people in the emergency department rather than a certified law enforcement officer who needs to be back home answering calls. So those two recommendations, and of course the overriding long-term, possibly long-term solution is more beds. But until we get there, we would ask you to consider those two possibilities. And I know, just trying to answer some of the questions, what do we do? You get a TDO, you transport the person to the emergency department, and we change shifts. Instead of the deputy going to work, he's going to the emergency room. And that's going on. The longest I've heard of is 6 days, but I'm hearing days much more often now than we were a year ago. And so we hope you can help us stop the bleeding, but as importantly, we hope you can help us with the long-term solutions. We just need more beds, whether they're private or public. I don't know the answer to that. I enjoy hearing that maybe you're looking at putting funding toward private beds, and I agree with the recommendation that if you do that, let's make sure they're available for TDOs.
Right.
Thank you, Mr. Chairman, and I'll answer any questions you might have.
Thank you, sir. And I think as we ask Jennifer Wicker and others to give us data and statistics on where this is happening, if you would survey your membership and see if it is a predominantly rural versus urban discussion, but also while you're doing that, if you could help us with where is it working? I mean, there's a drop-off center at the Williamsburg Doctors Hospital run by Riverside, and I know that they seem to think they only operate 12 hours a day, so they hit capacity pretty quickly. But is that a place that is something like that? When your Gloucester sheriff talked about the 70 hours, that immediately triggered for me to see, I wonder why he didn't come across the river, and maybe he did. I don't know, but places that you're seeing it happen often or mostly, but also places you see it working would be helpful for us as we try to figure out what a short-term solution can be for this in advance of the long term.
Well, I'll do that, Mr. Chairman. I know that I hear good things about the drop-off centers. Sheriffs that don't have them in the rural areas want them. Sheriffs that have them want to keep them. I know it, and it's especially for an ECO, when there's in that first phase, that deputy can drop the person off and evaluation can take place, but not so much on the TDO because that's a long-term transport. And keep in mind, of all of the people here on this call today, we're pretty much the only ones that have no choice. The buck stops at the sheriff when that judicial order is entered and given to the sheriff. He's required to serve it. He can't say, well, we're full or we're going to divert. He's looking at the magistrate and would be looking at the judge. We're going to take the person into custody. We have to do that. It's our job. And that's why the bottleneck is with the sheriff's office and the police.
Sure. Deli Watts.
I would just jump in on this and say it was so successful when we finally were able to open it in Fairfax County a couple of years ago that the sheriff's office, before it was open, agreed to 24/7 staffing from sheriff's staff, that it was more important that a sheriff be there in the center to free up any other law enforcement, and the commitment was made by the sheriff for that. I throw that in not just because it's particularly appropriate because of the volume that with our population, but I think it is also a way that we might look at the combination of staffing expenditures that might be put into this, and that whether or not it takes a change in state code where it doesn't have to be a sheriff's deputy, or whether we look at the staffing of sheriff's offices for such a center and adding additional staff for the sheriff's deputies designated for these centers. I think this is another way of better deployment of personnel than what we are currently dealing with.
Mr. Chairman, I would follow up on that and say that, you know, the compensation board provides the funding for the sheriffs based on the funding the General Assembly provides the compensation board. Currently, we are 254 law enforcement deputies short that are not funded. And that comes to the 1 to 1,500 population that's in the code.
Wow. Thank you, sir. Ms. Faison, something to add?
Yes, if I may, I just wanted to say again that there was a pretty extensive report that the BHDS put together on CIT and CTAX in particular, and I don't know that we would, as an association, support all of the options that were presented in that report, but it does give you a very good idea of what it would look like to expand upon the existing CIT infrastructure that we have, and gives an idea of the cost of expanding existing CIT so that they can be 24 hours, if that makes sense. I mean, in many instances, it's just not going to, because you're not going to have you're not going to have the need for that in every area, the 24/7. But to use data to drive decisions on how to expand, maybe it's only 3 days a week and you'd like it to be 7 instead of 24/7, just expanding the number of days. So I think that going back into that report and taking a look at some of those options for expanding CIT really does make a lot of sense, because again, if this group is focused on trying to get at the law enforcement piece of this problem, and as you've heard, I mean, there's pressure on law enforcement, but there's pressure on every single one of the stakeholders that's involved in this process. And I think in particular, the CTAC conversation is very salient if, to the sheriff's particular concern.
Yes, ma'am. Thank you. You did bring that to our attention at the joint subcommittee, and I neglected to get my hands on that. So thank you for reminding us. Maybe if someone has access to that, if we could fire that out to the members of the subcommittee. Thank you, Ms. Stanton. And if you said you might, endorse some of the recommendations and not others. If you would give us your thoughts on the ones that you would recommend, I think that would be helpful to us.
Sure. I'm happy to dust off that report myself and jump back into it and familiarize myself and provide you with that, of course.
That'd be great, because Delegate Ranson and I were talking about the Northern Neck. There are a lot of counties in one area that, if we could find something that could service that whole region, that area, versus what they're doing today, but more importantly, figure out how they're handling it today. That may be a step towards a solution, whether that's a drop-off center in and around an existing hospital, or even a company that comes in and may be interested in setting up some sort of mental health urgent care. I don't know. I'm just talking out loud. Delegate Watts, something to add, ma'am?
No, I really thought that I took off. I thought I was being good.
No. I'm sorry. You just were off mute. I thought you were.
No.
My bad. So before we go into kind of our brainstorming and maybe a discussion on the pilot projects that have funded and what the commissioner has in mind for that, did we have any public comment? Did anyone sign up to speak to the subcommittee? Could we go ahead and do you think now would be a good time to take public comment?
Mr. Chair, we do have several people who are in attendance here. And what I'll do is ask those who are in attendance if they would like to speak to the work group. If you could please digitally raise your hand now, and I will bring you into the room. And currently, sir, we have one.
Okay.
We're coming in here. All right, so they're starting to come in.
Okay.
We do have a couple. Currently, there are 3 members with their hands raised. We have Anna Mendez, Bruce Cruiser, and Jonathan Green. I will bring Anna Mendez into the room, and then Bruce Cruiser can speak after her.
All right. I think most of us know Ms. Mendez, who speaks to us on a regular basis. But please, if you would keep your comments to around 3 minutes or so, tell us who you are and maybe hit us with a topic that you would like to discuss and give us your thoughts. Ms. Mendez, nice to see you, ma'am.
Good afternoon. It's nice to see you as well, Chairman Mason. My name is Anna Mendez. I am the Executive Director of a Partner for Mental Health in Charlottesville, Virginia. I wanted to take a moment to respond to a few things that I've heard this afternoon. The first thing I think that is incredibly important is I couldn't help but notice that the title for our discussion was Options for Reducing the Impact of ECO, TDO, and Bed Shortage on Law Enforcement. And I have great respect for members of law enforcement, but I do want us to prioritize centering the experience of the person who is themselves in crisis. And if we could come up with a solution to this problem of people boarding in emergency departments that actually increased the impact on law enforcement, but made things better for the person, I would hope that we would find a way to be able to support that. Now, I'm not suggesting that's what we do, but I just want us to keep that priority is, I think, should be incredibly, incredibly important. The other thing that I would like to say is to remind us as well that only Wyoming and North Dakota have more inpatient psychiatric beds on a per capita basis than does Virginia. And I think it's important to keep that in mind, that if building more beds was going to be the solution to our problems, that we would potentially have fewer problems than we do right now. And as Ms. Faison mentioned, we do need to be willing to be uncomfortable with our funding. She said it so beautifully, I'm going to say it again. For a time, we are going to need to be able to both fund the system that we have while building up our community-based services. And if what we do is to continue to build more beds, but not to also be willing to invest twice as many dollars for every hospital bed into community services, then 20 years from now, we're going to be having this same conversation. The last 2 things I want to say is I helped launch the CTAC Center in Kilmarnock that serves the Northern Neck and the Middle Peninsula. It was incredibly successful, and we would love to see that system as part of a statewide solution. We also, Chairman Mason, I smiled when you mentioned how surprised you were to hear that people aren't receiving intensive treatment or treatment in the emergency department. They're not. And we think that they should if they're spending any length of time there. And we also believe that their time there should be part of their TDO. We are quite concerned about the liberty implications of people being stuck for days in a dubious legal middle ground between their ECO and their TDO. Thank you very much.
Thank you, ma'am, for your comments. You always do a great job of giving us a patient perspective. And my apologies for the law enforcement angle of that. I think Delegate Hope started us off with the importance of looking at this through the eyes of the patient and the person that needs the services the most. So thank you very much, ma'am. We appreciate those comments.
You're welcome. Delegate Hope does that very well. We're grateful for him.
Mr. Jackson, next.
Mr. Chair, we have Bruce Cruiser, followed by Jonathan Green.
All right. Mr. Cruiser, thanks for joining us today, sir.
Yes, thank you, Mr. Chair, members of the work group. Yeah, my name is Bruce Cruiser. I'm Executive Director of Mental Health America, Virginia. And I certainly commend the work of the state hospitals and the private hospitals for what they've been doing, as well as the CSBs and, of course, the sheriffs and law enforcement. I think all the advocates recognize the tremendous effort that everyone has been putting into trying to deal with this crisis in the most humane way possible. I would echo the remarks of Ms. Mendez about the solution not being more hospital beds per se. To kind of reframe the need is really more safe treatment options for someone in crisis. And that means having more tools in your toolbox. And Virginia doesn't have those tools in the way that some states do. And there's a plan in place so that I really think that by this time next year, we'll be out of this. We'll be hitting soon the 988 emergency number for mental health crisis. And the Marcus Alert system will be going. We'll have the department's planned sort of mobile crisis and coordinated crisis teams in place, diverting people on the front end, the upstream solution. Because the reality is, the more you have the community continuum, the care options in the community to help people before they're in crisis, and then as they are getting into a crisis, to prevent them from having to be transported so far away to a state hospital, which is really more designed and is our only option for long-term mental health care. But the more we can keep those folks closer to home and provide the diversionary, less intrusive treatment options that are shown to work, then the less need we'll have for more expensive beds. So I do think the department has a plan for us to get there. And it doesn't help today. I understand that. But I think by the time you'd have more beds constructed, we'll have a system in place that will be a lot more humane, a lot more effective, and a lot less expensive than trying to build more beds. In Arizona is a case in point where they've, through their extensive crisis program, they divert as many as 40% of their emergency room calls to non-hospital options, and successfully. So there's really encouraging work out there that's being done across the country, and I think the department and as well as the private hospitals are working to get us there. In the short term, an immediate issue, I would just say, if we can build incentives to get more staff, we would support that. Using some money to get the people working in the hospitals. I heard Ms. Wicker say we've got beds in the private system, but we can't put people in them because we don't have staff. And that problem will still be there if we build more beds. They won't do us any good unless we have the staff. So let's put the money right now to help provide incentives to get trained people in the hospitals where they can open those beds. And also, if we need someone to stay with a patient in the emergency room, we've got certified peer recovery specialists around the state who have been there themselves, and they can relate one-on-one with people. And some of the CTAC centers have used peer specialists. In fact, in Enrico, they've used one in the CTAC, which is on site with the hospital, to provide that support for someone while they're sitting there in crisis. So I would support any way to incentivize that. Thank you for your time. And again, I appreciate the work that the work group is dealing with. Thank you.
Thank you, sir, very much for your remarks. Mr. Green.
Can you hear me all right?
Can hear you, but we can't see you. Go ahead, sir.
All right. Thank you, Mr. Chairman, members of the committee. Jonathan Green, the Director of the Department of Magistrate Services with the Office of Executive Secretary. And I'd just like to share a very brief perspective from the magistrate's point of view, as we are the only officials that can issue a number of the mental health ECO and TDO processes that are often at the heart of these matters that this group is discussing. In issuing these processes, magistrates follow the language of the Code of Virginia and also some interpreting opinions of that code given by the Attorney General's office. And we, from our perspective, understand the problems that stakeholders are facing right now due to lack of bed space, the impact of the COVID pandemic on hospitals, manpower shortages in rural law enforcement agencies, et cetera. And we emphasize with those, but we are also seeing from our perspective where the system is failing people on a regular basis because of these stressors. We see firsthand when law enforcement is having to spend days on scene in an emergency department because sometimes magistrates are contacted again to ask if there's anything we can do to alleviate that. And usually the 9 times out of 10, the answer is no, there's nothing else that we can do. We also see cases where due to staffing issues, frustration, or other things, executed TDOs are being, for lack of a better term, unexecuted and returned to the magistrate's office, and presumably the patient is then let go without ever getting to the hospital that they were directed to go to. The long and short of it is we're all aware patients aren't getting the help that they need, and it's particularly frustrating for magistrates at times because we are asked to do things that we do not have the authority to do. For example, in cases where patients have been released early, or at least where the TDO has presumably been unexecuted, we are then asked to follow up immediately with another TDO. And there are some legal reasons why we are often unable to do that, which doesn't help anyone and causes a lot of frustration. So I share that with you just to say, I appreciate the efforts that everyone is making to try and address these problems. I know they've been here a while, but we really seem to be reaching a critical point where we need to find some solution. Otherwise, there will be a bad outcome somewhere. Thank you.
Thank you, sir. Is that it, MJ?
If there is anyone else in the waiting room who would want to speak, please raise your hand digitally, and I will bring you into the room. Mr. Chair, no more hands are raised. I believe that's it.
All right. Thank you very much, sir.
You're welcome.
So I was glad to hear Mr. Cruiser say that he thinks in a couple of years we'll be through this with the 988 situation with the call center. But our charge is, what do we do now? So as far as our group, so can we start, Commissioner Land, with two things? Do we have a lawyer in the family here? Is Ms. May a lawyer?
Yeah.
Okay, I thought so. Can we speak to, are all of these situations, when they get to the emergency room, are they already under TDO? Or is that something we need in the data that we're looking for? I'm really interested in the legality of holding someone for 70 hours. And maybe we don't have enough data for you even opine on that. So if you do, you don't have to do like Ms. Faison and pretend to ask a good question. That's a really bad one. But then I'd like Commissioner Land to speak to the pilot that we've already approved and how we're going to move forward to that. But could you start with how most of these folks end up here legally?
Senator Mason, I can talk about that if you'd like to. Taylor can fill in as she needs to. So I think that's one of the questions we need to understand in part of this process is what exactly is the legal status of these individuals at this point in time, like when they're being held. We know people coming into the ECO, and that's a really short timeline. And then we're talking about having a bed where we can treat people during the TDO. There are strict time limits on the TDO as well. And some of the time limits I've heard discussed today do raise questions about the legal status of the individual while they're in the emergency. So I think it would be helpful if we could pull some data about, how long are these longer stays that we're hearing about? How many cases do we have that are exceeding the time limit that we see under a TDO? are these cases, are these people under a TDO while they're waiting? If not, what exactly is the legal authority under which they're being held? Because the TDO might have expired.
Right.
It would be helpful to get regional data so we can look into that. I can work with DBHDS and probably a couple other sources to see if we can get a better picture of the scope of this problem. Is it a lot of people who are waiting 2 or 3 days? We heard about 10 days. That really does raise some questions. But I think we can pull some more organized information to give us a better sense of the scope of the problem.
Okay, excellent. Thank you, ma'am. And my apologies. Earlier you said she was with the courts committee. That made me flash back to my days in the House. I think I just can't get beyond it. So I'm sorry. I apologize.
I try to defer to her if I could, but I can answer that.
But I think that's exactly. We really need to see, are we pushing the bounds? What do we do? How many situations? So that'll go along with the data. Commissioner Lamb.
Hi, everybody again. Let me see. Can you hear me?
Yes, ma'am.
Okay. So you wanted to hear about what we're looking at for the pilot projects. And if y'all will remember from my last presentation at the full session, we have an extreme barriers list. And so what we really have focused on is those larger buckets of patients. I call that a bucket. We have a certain barrier that's keeping them for long lengths of stay. And if we can figure out how to get, because we have like 225 or 30 patients that have been there and way past their ready for discharge date. And so that's a big way that we could, if we could figure out the solutions, that we could make some impact on the census. And so we focused on, we talked about the dementia cases, or those folks that are geriatric and needing to go to long-term care, ALF, or other, supervised residential settings that typically they don't even want to hear us asking for a referral to them. They just hear they're coming from the state hospital and they just say no. And so working on some solutions to that. From the pilot perspective, we had originally 3 identified, and Jennifer can talk more about this or support me in this, 3 identified when we went and got the approval. And then the pandemic hit almost immediately. We were well into discussions and moving forward. And as the pandemic hit, 2 of the 3 backed out of those hospitals. And I'm guessing it was for financial reasons because everybody was having financial issues. Carillion, we are at the point of contracting and signing contracts. We've gone through all of the proposals and made all the fine tunes and redlined everything and negotiated. And so we're ready with Carillion, and they're going to do a CPAP, the Psychiatric Emergency Center for Adults. And so they've actually already piloted it, and this will be an expansion of it, and it's been very successful. And so we're hoping that this expanded pilot will show that across the Commonwealth, if we do these types of programs, that we can see a good result. The second one that we're looking at, we had Riverside approach us about doing a program for the substance abuse population and the detox, the people that need detox. And their proposal really is to expand not the number of beds that they have currently licensed and COPN for, but they have beds, their beds are all semi-private, and they typically have about 10 to 12 patients in their beds that have a no roommate order. And so if they can make their rooms private, then they could go ahead and accept more patients. So they're going to do that. And we're going to help them with some of the cost of the one-time costs for that, but also for, some of their additional supplemental staffing needs and things like that, to make sure that the pilot, it shows that works and makes it more successful. They're also going to be doing, having some of them specifically, I think 6 of those patients' beds will be for inpatient detox. And so they'll have a separated area that's strictly for detox, and they'll get very good at it. And those follow-up services for their long-term recovery, and with all the case management and all of that and the care coordination that has to go on. And so that's the second one. And then for the third one, and Jennifer could probably tell me, I don't know exactly how close they are to submitting their proposal, but then it would just be getting into a contract form, but it should be pretty quick. And then there's another group of patients that are on the EBL list that are the NGRI, the not guilty by reason of insanity folks. And so we are looking at piloting potentially with WellPath for a solution of 2 group homes to help with that population. And so we're hoping that we can move down the road with them where they're not as close as where we're at now with, especially with Carillion, but then with Riverside. And then hopefully, Jennifer, if we can't make it with WellPath, then Jennifer will, one of the private facilities will come forward with another solution. And we did do a contract with CHKD for those additional beds that in their adjacent to their ED that can be used for, 20 to 48 hours of observation, and they have a bridge clinic in their psychiatric practice. So hopefully to stabilize and then move them to outpatient treatment. And so we've got a contract with them. We've got an RFP out on the street right now about our largest group, which is the dementia patients and those needing that long-term care ALF and other residential programs. And so we're looking to that closes, I think, in the next 10 days, week or 10 days. And so we should have something moving on that pretty quickly as well. And so if we feel like that, if we can get those main things, and we've also done a pilot out in in the southwest area with the Mount Rogers CSB and Valley Health, which is a new long-term care. They were purchased, I think, by Innovative, and it's called Valley Health, and they've got a 46-bed unit that they are doing as a behavioral health unit. So anybody who's coming out that needs long-term care from our facilities is eligible to go, they'll look at for a referral, and we put in additional supports and services and activities, coordinators and things like that. They've gotten psychiatric and psychological supports that are coming in, and we've, so they also want to expand it to 60 beds. And so if we can see that type of pilot works, then maybe we can work with other long-term care providers across the Commonwealth to build that competency of their staff and have those additional supports and services available. Because, we have a large number of geriatric patients that, first of all, shouldn't be in our facilities. So if we can get our folks out and into these facilities and we see that it works, then we could also divert from coming because they would be eligible to be referred into those programs from the ED or from home or from, their family so that they didn't end up in the ED and then get PDO'd to the state hospital. So those are some of our main areas. Does that help?
Yes, ma'am, it does. It gives us an idea of what's in process. Where is the Carillion facility, or is it in multiple of their facilities?
It's in Roanoke.
Just in the mothership? Okay. Mm-hmm. Thank you. All right. Any thoughts from the Delegate Watts?
Two things. One, I know I need somewhere, I don't know whether it was Commissioners Lands or Jennifer Wicker's presentation, someone made reference that upwards of 20% of the emergency room admissions involved mental health issues. And so, pardon?
It would be behavioral health. It could be substance use or mental
substance abuse, etc. So while I don't want to divert, Mr. Chairman, the focus of what we're here about, which is the emergency custody order and the temporary detention order issues, I really need to have a understanding of the magnitude of what we're dealing with. And certainly it was mentioned that there are more evaluations and less TDOs, which is good as far as community health. So somewhere in putting together all of this so that I understand the magnitude of what we're dealing with in both community service board services that might be in the hospital, ability to back up the emergency rooms with whatever they're dealing with, whether it came in officially or not. This is a population that I need to better understand what we're really dealing with. And I think that's particularly true for children, where I assume that they may be coming in more unofficially, and certainly for drug abuse. And one other point on drug abuse, I think I heard the commissioner say that it's a one-time expense. This is another one which could go into COVID one-time funding, relieving funds for the ongoing that we need to carry, because again, as the figures that I've read is the overdoses, deaths by overdose have doubled during COVID, and for a lot of reasons, and some of them being that services have not been available as someone has just sat in isolation. So these are all things we can tie to COVID impact.
Thank you, ma'am. Delegate Hope, I think Ms. Faison may have come in to add on to that. Did you want to add on to that, or do you have something different?
I just wanted to make sure that do a check on myself. When I was talking about the TDOs and the evaluations, to clarify, the number of evaluations have increased, but the number of TDOs have remained constant.
That's what
If I didn't say it that way, that is the way it is. Yeah.
No, I think that's the one I asked the bad question on, so I may have screwed us up. So thank you, ma'am, for that. Delegate Hope.
Thank you, Mr. Chair. I just wanted to share where I am on this, and I appreciate everyone's perspective on it. I don't want to just solve the problem of law enforcement sitting with a patient for a number of hours. I'm much more interested in solving the problem with the patient. And if we do one without the other, I think we're making a big mistake. And so I, for one, would be interested in putting a proposal together, and we need data to know where exactly which regions this should be, where this should be directed. But I would be interested in a proposal that would fund private hospital staff. So we want to get away from beds. They have the beds, the staff to support the beds that they have. And it could be on a temporary basis, because I think we all hope and pray that the other stuff that we're working on is all going to start to kick in, and over time will relieve this pressure. But I think this is a good temporary solution that solves both problems. And so I for one would like to see a proposal as to how much that would cost, and let's make sure we limit it to only those areas that need it the most.
Okay, I think that's an excellent suggestion. And I would just like to link in the telehealth opportunities that Ms. Wecker spoke about in advance of that as well.
Can I add
Yes,
one
sir.
thing? I just
Yes,
want to
sir.
add one thing. I want to make sure we're talking about TDOs here. And so to the extent that the hospital facilities need to be taking, these beds need to be TDOs.
Yep. Commissioner Land, do you have something to add, ma'am?
I just really think that the biggest opportunity I think that the state hospitals have is from an operations perspective, finding these solutions for getting the people, when they're ready for discharge, to be discharged, and getting, being able to do 7 days a week. We can't keep operating, 5 days a week or 4.5 days a week, because by the time they get in on Monday, they have to do all the treatment planning for the patients that came in over the weekend. So they're not doing any discharges really on Monday or many on Monday. And then on Friday, they're trying to get people out, and they may not be doing as many admission orders and things, as they're trying to get them out before the weekend. And so I think that we need to make it so that we have a steady operation, so that we get that throughput build up, but we have to get folks being willing to accept these patients, either confident to take them in the case of long-term care facilities that don't feel like that they can manage them, or getting it to where facilities that they don't belong in our state hospitals. They shouldn't be coming. They're medical issues, not psychiatric issues, and shouldn't be there. I think we have just a huge opportunity to really make an impact on the beds. And then our staffing is so short that we are actually having a ton of assaults and aggressive things and serious incidents that are occurring both to staff and to patients. And we have to work on getting that staffing improved. But everybody has workforce issues. We also have, 100% TDO patients in our facilities, no voluntary. And it's it's unsafe.
Well, and as Mr. Tweedy took us through what was funded and what wasn't, security at our hospitals was the only thing that was zeroed out. So we should probably think about that. And I know that you've had some conversation. You've really been harping on this discharge process. And I know with your budget request this year, you had some other ideas. But you mentioned earlier that you have a work group going on right now that I'm sure includes the CSBs and the people that are doing it today, plus your hospitals. If you could just keep this group informed on ideas that come from that, I think that would be helpful as we move forward. Delia Ransom.
Yeah, and I don't want to end with the last word, but just with Commissioner Land and Ms. Wicker, once the TDO comes in, just the telehealth is so critical in the rural area. Just providing some type of stabilizing care in that ER, to me, is critical. When they're coming in crisis, being able to stabilize the patient immediately, to me is I think really something that's critical right then and there. That, just for what it's worth, is important.
No, it's very important, I think.
Mr.
Wicker,
Chairman?
yes,
Yes.
ma'am.
Thank you. I would be remiss if I did not take just a moment to make a statement related to the voluntary and involuntary patients. Delegate Hope, I have the homework that you have provided to me, and I will work on that proposal and understand that the priority is around the TDO patients because of the stress that our state facilities are under. But I have to say that just because an individual ends up in the emergency department and they're there on a voluntary basis, it does not mean that their needs are any less severe or important, because they are not required to be temporarily detained to receive that care. And although a lot of the conversation that we have is around that TDO patient, I just don't want us to forget about those voluntary patients who also need assistance, who also need care, and sometimes need that in the inpatient setting, and don't really show any different type of characteristics just because they're there on a voluntary basis. So I just had to say that for what it's worth.
Well, I'm glad you did, because you have now highlighted the friction that's always been there. You know, if you want to make the hospital's head explode, say cherry picking patients, right? Patients that maybe have insurance, patients that they're in crisis, but they may be at a different level. And so we have to have that as a part of this whole conversation, because again, this is something that I haven't been involved in it that long, but I've heard this from the very beginning when I started focusing on this. So if this group can determine and make some impact, I think it'd be super important. So our takeaways, Ms. Stanton is going to find us some kind of legal DBHDS implications. How are they there? What's the process? What are we seeing there? Ms. Wicker is going to try to get us some numbers as far as, long stays in the ED, and by region, by area, by hospital, just data. We need data to see what we're working from. I think Mr. Jones is going to maybe survey his folks and determine where he sees this as an issue. To Delegate Ranson's point, is it a rural issue? Or as well as at the same time, if he would help us with places that are doing well. Commissioner Land's going to keep us up to speed on the discharge planning, because obviously freeing up the beds we have. And I guess the big deal here is can we fund and can we find the appropriate workforce and the resources, the human resources that we need to help these patients when they're in this situation. So did I miss anything on the recap? What kind of time, Mr. Jackson? Oh, you're on mute. Can anyone hear MJ? Hey, you're on mute, boss.
My apologies. I was trying to say that Sarah was muted. So my apologies.
The brains behind the operation are all muted, and I'm the only one babbling. This is a problem. Sarah, did you have something to add?
No, I was just saying, I think that works well. We'll work on the legal status. Jennifer Wicker, I have to specify which one. Let's talk, you and I, offline a bit about how we get the data. I've got some ideas on how we can drill down into that data as well to identify beds that have licensed, or hospitals with licensed beds that are not currently staffed. That's the resource we can look at. We can pull this information together. And my question for you, Senator Mason, was going to be, at what point do you want to have our next meeting?
That was a great one. And Jennifer Faison was going to look at the drop-off center report from a few years ago and speak to some of the recommendations that they thought were beneficial that we may have not have seen come to fruition. We're on a short timeline here and of course, we've charged folks with drawing kinds of data. What kind of is the last week of May? Is that possible to pull us together to have some information? Go ahead, Sarah. I'm sorry.
So one question, and MJ will need to help us with this. We are, I think, still supposed to try to limit our meetings to the Monday, Tuesday, or Wednesday of the first or third full week of the month. If we're going to meet, and that's been a longer standing rule now. If we're going to meet outside of that, we just have to get permission to do so. And I think we can look into that, but just wanted to make you aware of that. So we could look at the week of May 17th, and then the first week of June are sort of official sanctioned meetings. And if we need to be outside, we'll just get permission.
Sorry about that. I didn't even know I was breaking a rule there. I appreciate that. So MJ, would you send out to the group, if the only caveat I have is if the week of the 17th, that seems really quick for some of the information that we've asked for. But if the folks that are helping us pull the data and have the information feel like we can do it by then, I'd ask maybe MJ if you could send out a poll to see 17, 18, 19, or 31-1-2.
Well, excuse me, Mr. Chair, it would actually be the 7th, 8th, and 9th would be the sanction.
Sorry about that. Okay. All right.
So if you want me to do for those two weeks, I can poll for those dates.
Is the 17th too quick? Jennifer Wicker says yes. Yeah, I was afraid so. We like quick, even in Delegate Watts.
So if we're moving then to the 7th, 8th, whatever that week is, I want to add to the agenda identification of that which can be funded by the American Rescue Plan. Because of the special session coming up, we want to get our focus in there.
Excellent. Great. Thank you, ma'am. That's a great call. Okay, so we'll shoot for 7, 8, 9 to see how that works for the group. Anything else from committee members? Anything else from our presenters? And how about the team that holds us together? Y'all got anything? All right, awesome. Hey, thank y'all very much. We covered a lot of ground. Really appreciate it, and look forward to the 7, 8, 9 and the ideas that may stem from. So thanks, everyone. We're adjourned.
Thank you, sir.